In this chapter, we present the endoscopic techniques that we developed for the treatment of nonsyndromic craniosynostosis. By way of disclosures, we have no financial or legal relationships with any of the helmet, endoscopic, or instrumentation companies. The modern surgical treatment of craniosynostosis began in the 1890s with simple suturectomies. These were modified in the 1950s with the addition of larger craniectomies. In the 1970s, the concept of calvarial vault remodeling was advanced by the development of craniofacial surgery. In the 1990s, we conceptualized, developed, and introduced the minimally invasive endoscopic craniectomy technique, followed by calvarial orthotic therapy. As these surgeries were developed, our goal was to improve the care of the patients by minimizing tissue dissection and exposure, decreasing operative times, blood loss, transfusion needs, but most importantly, to improve the long-term outcomes of the patients. The basic principles that underlie our approach include the fact that during the first year of life, the dura regenerates any calvarial vault bone which is removed, that the brain grows extremely rapidly during the first year of life, and that the brain, with its unrestricted growth, drives the shape of the face and the head. We believe that the suture stenosis itself is the primary culprit for the subsequent craniofacial abnormality seen in craniosynostosis. That releasing the closed suture at an early age allows the brain to resume its genetically driven growth pattern, and it leads to correction of the craniofacial deformities, and that sutural release should be done as early as possible. The techniques are relatively simple and involve the use of one or two small incisions, the use of rigid endoscopes for excellent visualization, the removal of the stenosed suture, adequate hemostasis, and post-surgical helmet therapy. Contrary to traditional open CVR surgery, we use no arterial lines, no central lines, no Foley catheters, no drains, only utilize one or two peripheral IVs, and use a precordial Doppler for monitoring for air embolisms. In our series of almost 1,000 patients, sagittal synostosis comprises 54% of the cohort population. Metopic is the second, recently surpassing coronal synostosis at 19%. Multiple synostosis are 6% of the group, and the least common, of course, are lambdoids at 3%. This slide shows that the median age at the time of surgery for our patients is around 3 months for most sutures. The estimated blood loss is minimal and has consistently been calculated to be between 1 or 2 tablespoons for most sutures. Listed here are the transfusion rates in our series for each of the affected sutures. Almost all patients were discharged on the morning following the surgery. The overall surgical time was 53 minutes for all sutures. Looking at success, meaning normalization of deformities and maintenance of correction over time, we have seen that a simple suturectomy will lead to some improvement over the short term, but with regression over time as seen in the blue line. Some maintain improvement in yellow line. However, when placing patients in helmets, we have documented marked and significant improvement over long periods of time, with some patients having follow-up over 20 years. A lot of negative press has been given to helmet therapy. However, we have found no negative or ill effects from the use of these helmets over the past 20 plus years. And perhaps we see even some good side effects, as shown in our second sagittal patient, who now still wears a helmet as he flies Apache helicopters for our armed forces 23 years after his surgery. Rather than to simply say that the patient looks good to the parents and the surgeons, we document our results with extensive anthropometric data. Our patients very closely during the first years of life and documented with the scanner. Having treated patients with over 2,000 helmets, we have documented clearly that there's no restriction on head growth. We will now present the treatment of sagittal synostosis, which is more than a strip craniectomy, as we advocate the use of a wide vertex craniectomy with bilateral barrel stave osteotomies. Shown here are the locations of the two incisions. The anterior incision is behind the anterior fontanelle, and posterior incision is immediately in front of lambda. For the endoscopic treatment of sagittal synostosis, the patient is placed in a sphinx position. After prepping the patient, the first incision is made across the midline and behind the anterior fontanelle. It is made with a monopolar electrocautery, needle tip set at 15 watts. The second incision is made immediately in front of the lambda and taken through the galea and subcutaneous tissue in a bloodless fashion. Subgaleal dissection is made with monopolar in a plane below the galea and above the pericranium. This is done in a totally bloodless fashion, taking care to cauterize any bridging veins. Dissection is carried out from the anterior incision towards the posterior incision, thereby exposing the entire subgaleal plane between those two. Retractor is used to elevate the scalp. The osteotomies are done first by placing a single 7 mm burr hole on the right side of each incision and then developing the osteotomy with kerosene rongeurs. Number 1 Penfield is used to free the bone from the underlying dura across the sagittal sinus. Here we can see a 5 mm kerosene being used to make the osteotomy in the posterior incision. For epidural dissection, a 30-degree rigid endoscope is placed between the bone and the dura and advanced posteriorly in tandem with a coated suction tube. This allows for dissection of the dura from the overlying bone as well as to keep the blood from the endoscopic field. Not uncommonly, one will encounter a bridging vein between the sagittal sinus and the overlying bone, which, rather than tearing it, it can be easily cauterized under direct visualization with bipolar electrocautery, as demonstrated here. Once the vessel is cauterized, it's simply pulled away and dissection continued to the occipital end. Paramedian osteotomies are then created with either sharp Mayo scissors or bone cutting scissors. These are done on either side of the midline. Wedge osteotomies are made then after the bone has been removed. Brain ribbon is used to free the dura all the way down to a scomosal suture, and the scissors themselves are used to free the epidural plane or the plane below the galea. Scissors are then used to cut the wedge anteriorly, posteriorly. This is done in all four corners. Bone hemostasis is mandatory and can be easily achieved with the JMB dural retractor and suction electrocautery. The suction electrocautery is set at 60 watts. The diploic space is directly cauterized until all the bleeding stops. This is done in a circumferential fashion, including all the wedge osteotomies as seen here, as well as the paramedian osteotomies. At the end of the operation, the 30-degree endoscope is flipped to allow inspection of the dura and make sure that there are no tears or any bleeding. The incision is then closed with absorbable suture. Craniosynostosis present with a number of complex deformities which are very difficult to treat once the patient reaches a year of age or more. These deformities include vertical dystopia, nasal deviation, strabismus, and cranioscoliosis. Our approach is to simply create a new suture as seen on this intraoperative photograph. It must extend from the anterior fontanelle all the way down to squamosal suture behind the terion. We also perform the entire procedure through a single 2 cm incision located as shown on this photograph. This video presents the technique for treating unicoronal craniosynostosis with an endoscopic assisted craniectomy. A single 1.5 cm incision is made at the Stephanian on the affected side using a needle tip Bovie on cut mode set at 10 watts. A rhinoplasty lighter retractor is used for developing the subgaleal plane towards the terion and then towards the anterior fontanelle as shown here. The fontanelle can be palpated to make sure that the area has been reached. A single small burr hole is made with a pediatric craniotome at the incision site as demonstrated. The epidural plane is carefully developed with the aid of a number 1 Penfield dissector to reach the anterior fontanelle as shown here. The osteotomy can be made with bone cutting scissors or bone cutting rongeurs. A 30-degree rigid endoscope is used to visualize the epidural plane before and after the osteotomy as shown here. The parietal bone has been fully freed from the frontal bone. Next, attention is placed towards the terion by advancing the endoscope and suction in tandem towards the greater wing of the sphenoid and the orbital roof on the affected side. Here one can see the greater wing of the sphenoid. The endoscope is directed posteriorly and inferiorly to reach the squamosal suture, which is the key anatomical landmark for full separation of the bones. Here it is. The osteotomy can then be performed once again using bone cutting scissors, Mayo scissors, or bone cutting scissors. Once the bone has been fully released, bony coagulation is obtained using the suction with the Bovie applied to it. You can see here the energy being delivered to obtain coagulation of the diploic space. This is done from inferior to superior and on both sides to prevent postoperative hematomas. Inspection of the surgical field is done, showing full release of the bones, parietal from frontal bone as shown here. Closure is done with absorbable monocrural galeal sutures and steri strips for the skin. Metopic synostosis can be successfully treated by releasing both frontal bones with the creation of a midline osteotomy, which extends from the anterior fontanelle all the way down to nasofrontal suture. A small transverse incision is made behind the hairline as seen in these photographs. Presented here is our technique for treating metopic craniosynostosis endoscopically. The patient is placed supine on a cerebellar horseshoe head holder. A bloodless incision is made behind the hairline with a needle tip Bovie. Subgaleal dissection is begun towards the anterior fontanelle. With the assistance of a rhinoplasty lighter retractor, the subgaleal plane is then developed towards the mid-forehead, also using the needle tip bovie to aid in a bloodless subgaleal plane dissection. This plane is fully developed down to the nasion using insulated brain ribbon retractors. The brain retractor is slowly and carefully advanced to reach the nasofrontal suture as shown here. A single small burr hole is made at the incision directly over the metopic suture. Once finished, a number 1 Penfield is inserted under the bone and advanced to the fontanelle. A small strip of bone is then cut to reach the fontanelle and release that area. Surgery flow is used for hemostasis. Once again, the number 1 Penfield dissector is placed under the bone and advanced towards the mid-forehead. The osteotomy can now be made in a piecemeal fashion using either Lexel rongeurs or bone cutting rongeurs as demonstrated here. The osteotomy slowly advances in a piecemeal fashion to reach the mid-forehead. Now a 30-degree rigid endoscope is placed under the bone to aid in the visualization of the bone removal. This allows us to then separate the dura from the overlying bone to do a bony resection in a safe fashion. On the left hand, you can see the suction is being used to depress the dura and expose the bony undersurface of the forehead. Now we see that the osteotomy has been completely done and the nasofrontal suture has been reached. In order to make sure that there is complete release of both frontal bones, an osteotome is used to free the nasofrontal suture as demonstrated here. This does create a small amount of bleeding at the nasofrontal suture, which is then easily controlled with suction electrocautery. The suction electrocautery is then set at 60 watts and slowly rolled from side to side, obtaining hemostasis of the diploic space as done in other surgeries. This maneuver is slowly done and advanced from distal to proximal to obtain complete hemostasis of the bone. An overhead camera now shows the same maneuver. On the right hand, the suction electrocautery is cauterized in the bone. The rhinoplasty lighter retractor safeguards the scalp from getting burned, and the endoscope allows us to see complete resection of the bone down to nasofrontal suture. Inspection of the dura is made to make sure that there are no CSF leaks or unnecessary bleeding, as demonstrated here. Surgery flow is generously placed on the suture and osteotomy site. Finally, the galea is closed with foromonocryl, and then the skin is closed with mastisol and steri-strips. There is very little swelling associated with this procedure and excellent results at the end of the treatment. Thus, in summary, we believe that endoscopic craniectomies for the treatment of craniosynostosis is in a safe and effective way. It is associated with minimal complication rates, and when the patients are followed for many, many years, the results are excellent. We believe that it is a superior alternative to calvarial vault reconstructive surgery and should be part of a full informed consent given to all prospective parents.